Hey, good morning, everyone, and thanks for joining. We're going to go ahead and start now because it's 9 o'clock. Thanks for joining our webinar on self-injection of DMPA-SC and experiences from Ghana, Malawi, DRC, Senegal, and Uganda. We're going to start off quickly with just a welcome and some housekeeping notes. So I'm going to quickly hand this over to my colleague, Megan Shawcross, so that she can just give you some details on our webinar today. I would like to ask that everybody just please make sure to keep yourselves muted during the presentation.
Thanks so much, Robin. Hi, everyone. This is Megan Shawcross from PATH. I just wanted to run through a few quick things about this webinar. All of our attendees will remain muted during this presentation. If you do have a question, we're asking you to use the Q&A function, which can be found on the black bar on the bottom of the Zoom window. So anytime you have a question, please enter it there, and do make sure to specify which panelist you'll be asking it for, since all of the questions will be addressed at the end of the presentations. If you do have any technical issues, please feel free to chat either directly to the panelists or to all participants, and I will respond to you privately if you're having any issues, so we can hopefully troubleshoot those. Other than that, if you have any technical questions, do feel free to reach out and I'll address those. Other than that, back to Robin or Jen.
Yeah, so I'm going to just, our facilitator, moderator today is Jennifer Drake. And she is the director of the Advancing Contraceptive Options portfolio here at PATH. So with that, I'm going to hand it over to Jen.
Great, thanks, Robin. Good morning, good afternoon, everybody from snowy Seattle, Washington. Looking forward today to hearing this discussion of contraceptive self-injection in 5 countries. This is actually a panel presentation that we presented at ICFP and have adapted slightly for a webinar, so I'm very glad to bring these results to a wider audience, hopefully, through this webinar. Is it possible to advance the slide, or do I do that? Sorry, guys. Thank you. You know, we're talking about one contraceptive option today, but every time we talk about a single contraceptive option like self-injection, it's really important that we begin the discussion by just checking in on the fact that all women, no matter where they live, must have access to a range of safe and effective products and innovations that enable them to manage their sexual and reproductive health. Before our panelists share their experiences from specific countries, I'm just going to go through a couple points on the product DMPA-SC that's used for contraceptive self-injection and why we're talking about self-injection today. Why is it a promising innovation for women? Next slide, please. So first of all, regardless of contraceptive self-injection and before DMPA-SC was even available, injectables have long been commonly used in several countries, most commonly the intramuscular formulation of DMPA. This is a graphic from a recent FP 2020 report, and the orange boxes represent countries where injectables are the most common method in the method mix. The countries where it's classified as method skew, which is representing over 60% of the method mix, have outlines in blue boxes, and so there are just a few of those. But the point is, injectables have been used by a lot of women for a long time. Next slide. So subcutaneous DMPA, or DMPA-SC, the brand name Cyanopress, manufactured by Pfizer Inc., is a new injectable, relatively, that's administered under the skin instead of into the muscle. And it's the first widely available self-injectable contraceptive. So when we talk about self-injection, this is the product that we're referring to. Next slide. I'm going to go through this relatively quickly. I encourage you to reach out to us at PATH if you would like more information about differences between these two products, and there will be a link at the end of the presentation where you can visit and get more information. But a couple key differences and distinguishing features of subcutaneous DMPA. It's pre-filled in an all-in-one injection system, so there's no issue of a vial with a separate syringe. I think many of you are probably familiar with the phenomenon that women will go to a health facility to try to get an intramuscular injection and find that syringes have been used for other purposes because it's separate. So there's an advantage of having this be an all-in-one injection system. As I noted, it's subcutaneous. That makes it easier to inject, and we've heard more comfortable for women. It also means the product can be self-injected, unlike DMPA-IM. It's a lower dose of the product in subcutaneous DMPA, and it's a shorter needle. Now, key characteristics of the two products in terms of safety, in terms of effectiveness at preventing unintended pregnancy, 3-month duration, et cetera, are very similar. Next slide. So all those various features of DMPA-SC add up to some specific opportunities and value that we hope to talk about today. So as I noted, DMPA-SC is a shorter needle, lower dose, all-in-one presentation, and it's easier to transport, inject, store, and has less waste to dispose. So these translated to a few different opportunities. The product overall, we've seen increased acceptability of DMPA-SC relative to IM. So for example, in 2012, I believe it was, FHI 360 published results that showed that in Senegal and Uganda, overall, women and health workers preferred DMPA-SC when both DMPA-SC and DMPA-IM were available. And overall, we've seen relatively positive results on acceptability of this product. Its all-in-one presentation and ease of use does make it well suited for new delivery channels in some places like community-based distribution and drug shops and pharmacies. And as I noted, the product is uniquely suited to self-injection. So what's the value here, the value add for DMPA-SC? It has potential to expand access and options for women, and there has never been a self-injectable contraceptive before. This is a popular method, and it gives women the opportunity to give themselves an injection at their own convenience instead of having to go to a facility. We've also seen that the product does tend to attract new users when introduced into a family planning program. So for example, about 1/3 of doses seem to be administered to new family planning users. That's first time or additional family planning users when the product is newly introduced. And when it comes to self-injection, we specifically see the potential for higher continuation, and I'll talk more about that in just a moment. Next slide. So I think, I just used a lot of words to describe the benefits of self-injection, but these words are probably some of the most powerful that I've seen. This is from a woman in Uganda who is self-injecting, and I think this quote captures the issues of convenience, of empowerment. She says, "I am in charge now. If I ever have another child, it will be because I want one." Next slide. So just to note quickly that the product introduction in general is ongoing in at least 20 countries, and this is an ever-evolving situation. Pleased to say that this product is becoming more and more available to more and more women. It is approved by stringent regulatory authorities, including for self-injection in the United Kingdom, and that regulatory approval has been and continues to be cascaded in many additional countries. Next slide. So just briefly, I referenced increased continuation, and you'll be hearing more in particular about this from Malawi, Senegal, and Uganda in a moment. But I think this slide captures the fact that continuation studies were done in 4 very different country settings, including the United States, comparing administration of DMPA injectables by a health worker with self-injection of DMPA-SC. And what the results showed in each country, all these 4 very different countries, was that women who self-injected had higher rates of 12-month continuous use relative to those who received injections from health workers. So we all know that continuation can be an issue with injectables, and that's for a lot of reasons. In some cases, side effects make it not the right choice for women. But in other cases, it may be issues like convenience or having to return to a facility every 3 months. And it seems that there's some added value of self-injection that's enabling women who want to continue the method longer to do so. Next slide. So Julia Cohn, who was one of the principal investigators of the United States study, captured, I thought, the kind of status of self-injection really well. There's a robust evidence base on feasibility, acceptability, effectiveness, and continuation, and you're all going to hear about that from 5 key countries today. But there's still a lot that we need to learn and understand about how to implement self-injection, and I think we're starting to learn that again in these 5 countries as they grapple with the results of these of the research studies and think about how to offer this option to women. Next slide. And so this is the final slide, just to summarize a couple key issues as we think about moving from research to practice. I hope you can keep some of these themes in mind and that we can bring them into the discussion. So for example, we need to decide in each country who trains clients to self-inject and where. Is it community health workers? Is it going to be at facilities? Hopefully it'll be at a range of outlets, including drug shops and pharmacies. What types of training aids do women want and need? Is it a one-page document? Can they learn through a video? Do they need to practice? Or maybe they can learn following along with a health worker demonstration. How do we assess whether clients in routine delivery settings are competent? And when are health workers, when should we tell health workers, okay, you can give these women units to take home to self-inject, because we want there to be access and we don't want there to be barriers. At the same time, we need to make sure that women know how to effectively prevent pregnancy. What approaches to household level disposal are feasible and appropriate? And how do we monitor this intervention as it gets integrated into routine systems? Because it's a little bit different than others have been. Next slide. So thank you very much. I'm really looking forward to hearing from our wonderful presenters today and to facilitating the discussion. So I'm going to turn it over to Della Nye from the Population Council to talk about her research in Ghana.
Thank you, Jen. Thank you for the opportunity to present our research. Next slide, please. I'd like to start with some background information. A 2017 national study showed an MCPR of 25%, up from 22% in 2014, according to the DHS. And a nearly 20-year trend shows that the use of injectables among currently married women has risen steadily from 3% in 1998 to 8% in 2017. And Ghana has made a number of FP 2020 commitments, where commitment number 3 specifically looks to increase MCPR to 29% among married women. And one of the sub activities of this commitment was to introduce cyanopress in peri-urban and urban facilities by 2018. And from this resulted the cyanopress pilot study, which was conducted between December 2017 and August 2018. Next slide, please. The objectives of the study were twofold. First, to assess the feasibility and acceptability of cyanopress with regard to service provision, training the client on self-injection, and then client self-injection itself from the perspective of the client. and then also assessing the feasibility of Cyanopress, introducing it in the country, and then the potential national scale-up. So in terms of design, we used a prospective cohort study of family planning clients who chose Cyanopress self-injection over 8 months. Next slide, please. Data collection was done over a period of 6 months. You'll see here we try to diagram it, looking at from your left, month 0, the first enrollment into the study. But I will say that some clients did not enroll into the study, but still took the still chose Cyanopress at that moment. And so we had the first injection 3 months later, the second injection 3 months later, the third. And for the purposes of data collection, we called it round 1, 2, and 3. And so at the first injection, clients had the 2 options, whether they were given 2 options, whether they would prefer for the provider to administer Cyanopress to them or for them to administer it themselves at the facility. And so those who did the self-administration also had the opportunity to take the product home. And so that meant that for months 3 and 6, or the second and third injection, clients had an additional option, which was home self-injection. Next. And so we collected data from, I'm sorry, could you go back, please? We collected data from clients through surveys. At round 1, the majority of the questionnaires were done at the facility, but for rounds 2 and 3, because some took it home, the questionnaires were done after the scheduled injection. And for those who declined, withdrew, or discontinued, we were able to formulate another type of tool in order to ask them questions regarding their choices. And so we also conducted client in-depth interviews among a subset of clients after the third injection. Next, please. And so the intervention was done really through the means of training, and this was done using a cascade approach. First, we trained the trainers. We trained 8 regional resource persons as master trainers. These master trainers then trained the providers from the selected 8 facilities, and all the providers who are involved in FB at each facility were trained. So a total of 150 providers were trained, and the majority of the trainings were done in 3 days, except in smaller facilities where the staff was smaller and therefore only necessitated 2 days. And so providers were using the PATH curriculum as well as other methods of teaching and training, were trained on several aspects of the product, including counseling, and then were trained on how to administer as a provider, and then also how to teach a client. And so then these providers now have the opportunity to actually put things in practice. And for clients who chose Cyanopress after counseling, the provider again gave them the choice of provider administered or self-administered. And for those who chose the latter, the provider trained them. And so those who were deemed competent self-injectors were offered up to 2 Cyanopress packs to take home, and as well as some Cyanopress self-injection instructions and a disposal container. And we can talk later about what competence meant. But I will say that clients were given the chance to practice using a non-human model before they were able to inject on themselves. Next, please. So in terms of the characteristics of our clients, at enrollment we had 568 clients. Nearly 60% were under the age of 30. To almost a little more than 2/3 were married and in union, and just about 50% had attained junior secondary school level. Next, please. In this slide, I just want to make the point that by round 2, 65% of clients had chosen self-injection, and we break it down by home self-injection and on-site self-injection for the purposes of those who want to see what the breakdown is. Next slide, please. In terms of acceptability, you'll see from these bars that there's a high acceptability among clients who took the product home and self-injected at home. In terms of satisfaction with the home self-injection experience, comfort, whether they would recommend self-injection, home self-injection to a friend, and in terms of their intentions to continue self-injecting at home. Next, please. Well over 80%, almost 90% really, experience at least one benefit of home self-injection. That was among clients who use this method of administration. And the majority of them talked about the benefits being reduced travel to the facility, being able to reduced wait time, reduced cost, as well as, but also increased privacy. Next, please. Disposal has always been one of the main points of contention, and so we trained everyone really for one method of disposal, which was to put it in a disposable container. And so clients were asked about what they actually did, and you'll see from these results that almost all correctly disposed of it by putting the used Uniject in the puncture-proof container, and found that this method of disposal was easy to do. But you'll see from the quote that some clients talking about how they did dispose of it in the container, but some of them did return it back to the health facility for further disposal. And just reflecting the fact that they were able to follow the procedure as they were taught during their training. Next, please. Reinjection is also another point that usually gets asked, and you'll see here that for the Ghana study, 85% reinjected on time. That is 11 to 17 week, during the 11 to 17 week reinjection window. And one of the clients said, I always refer to my calendar when my time is due, and so it makes things easier. And this is because this self-injection calendars is really well explained to the client during the training. Next, please. So what are the study implications? For us, we find that the implications are that clients can be effectively trained to self-inject cyanopress when it's done under supervision of a trained provider. Self-injection, a home self-injection is something that clients are very capable of, and are even mentioning reporting benefits of doing that. As Jen talked about increasing access. In our study, we found that 41% were first-time users. And so we really believe that it has the potential to increase access to contraceptives. And then we saw also that, one of the implications is that there's a high self-injection acceptability among self-injectors, regardless of FPUs. We were not able to show those data here, but we definitely did find that in our study and find it as an important implication. Next, please. So recommendations and actions. We had at the time of the conference, we had talked about these recommendations, but I'm happy to say that we've been able to utilize the research of this particular study to be able to inform a scale up. And as of January 2019, Ghana Health Service is developing a national implementation strategy for scale up in both the public and the private health health facilities, and they are using a cascade training approach similar to what was used in the study, have developed some M&E indicators for DMPA-SC, and have revised family planning registries to include DMPA-SC, and are working on an action plan for waste management, as well as guidelines for self-injection that are going to be included in the national policies and standards documentation, as well as shared with the nurses and midwifery associations. Next, please. Thank you. I'd like to acknowledge my co-authors, but I'd like to say thank you at this time.
Thanks so much, Della. And now we're going to turn it over to Holly Burke from FHI 360 to present results from a study and an update on self-injection in Malawi.
Thank you very much. Hello, everyone. I'm Holly Burke. I'm a scientist at FHI 360, and together with my co-authors, we would like to tell you about the one-year open-label randomized controlled trial we conducted in Malawi, comparing the continuation rates of women who self-injected DMPA sub-Q and women who received DMPA sub-Q from a provider, including community health workers in community settings. I will also describe the research utilization strategies we used from the trial's conception to accelerate the transition from research to practice. Next slide, please. Thanks. Our primary objective was to compare the continuation rates between women who self-inject DMPA sub-Q and women who receive DMPA sub-Q injection from a provider, including community health workers in community settings. Next slide, please. Our secondary objectives were to compare the reported side effects and pregnancy rates between the two groups and to describe the experiences of women who self-injected DMPA sub-Q and the providers who trained women to self-inject. Next slide, please. Providers recruited adult women presenting at 6 Ministry of Health clinics or to community health workers called health surveillance assistants in rural communities in Mangochi District, Malawi. Eligible women who selected DMPA sub-Q as their method of choice were randomized to receive DMPA sub-Q administered by a provider or to be trained to self-inject DMPA sub-Q. Self-injectors administered the first injection under observation and were sent home with 3 doses, written instructions, and a calendar. The provider-administered group received DMPA sub-Q and a calendar and were asked to return for re-injections. Data collectors, not providers, contacted women after the 14-week re-injection window at 3, 6, and 9 months to collect continuation data. 12 months after enrollment or at early discontinuation, women had their final interview, including pregnancy testing. We used Kaplan-Meier methods to estimate continuation probabilities and a log rank test to compare groups. We randomly selected 30 self-injectors enrolled in the trial to conduct an additional in-depth interview at discontinuation. We also conducted an in-depth interview after enrollment with 12 randomly selected providers who trained women to self-inject. Next slide, please. A total of 731 women were randomized to receive DMPA sub-Q administered by a provider or be trained to self-inject DMPA sub-Q. 1 woman was unable to self-inject at enrollment. Notably, over 70% of the women were enrolled into the trial by a community health worker in community settings. The mean age of women was 27 years, and 75% had no school or less than a primary school education. Next slide, please. We found that self-administration led to a more than 50% increase in continuous DMPA sub-Q pregnancy protection through 12 months compared with provider-administered injection. These results were highly significant. Also, there were no significant differences in pregnancy rates, adverse events, and overall side effects observed in the self-administered and provider-administered groups. Next slide, please. Okay, now I'd like to briefly summarize the results from the qualitative research. The self-injecting clients and providers we interviewed reported positive experiences self-injecting. Clients reported self-injection saved them time and money. Providers said self-injection reduced their workloads and saved them time. Clients reported safely storing and disposing of DMPA sub-Q as they were trained during the study. And clients trained by both clinic-based providers and community health workers were successfully able to self-inject. Next slide, please. In conclusion, through this rigorous trial, we found that self-injectors had significantly higher rates of DMPA sub-Q continuation than provider-injected women, and that community health worker and community-based provision of injectables for self-injection in low-resource settings is safe and feasible. Next slide, please. So during the planning and implementation of the trial, we engaged a variety of experts in Malawi through the Family Planning Technical Working Group to ensure the research reflected their policy and program priorities. This included selecting a research site that met their needs and incorporating their feedback into the study design and implementation. We presented the results to a range of audiences, including Ministry of Health stakeholders who have endorsed the results and created a task force for national DMPA sub-Q and self-injection rollout. Next slide, please. This slide illustrates our vision for research to practice, ending with national scale-up. You can see that it's a multi-step process, including not only the research and stakeholder engagement I just discussed, but also knowledge management, capacity building, reflection, and learning. Reaching national scale-up is a team effort involving many partners and a set of common goals. For example, we have finalized a national rollout plan, including costed budget, developed a national monitoring, evaluation, and learning plan for introduction. We've adapted curriculum, including training manuals, job aids for DMPA sub-Q as well as for self-injectors to the Malawian context. We've updated service delivery guidelines to include DMPA sub-Q and self-injection, and we're working to update the Open LMIS to include DMPA sub-Q and self-injection and strengthen the supply chain. Next slide, please. So focusing in on one of our goals, this slide shows the contents of the National Monitoring, Evaluation, and Learning Plan. This MELP has approximately 25 indicators, and getting it down to this list took a lot of time and discussion with the Ministry of Health, who wanted to be sure to not overburden partners and the system. The rollout is being conducted in 2 phases in Malawi. The first phase includes 7 districts and will serve as a learning process to inform the scale up to other districts. The goal is to achieve national scale by 2020. With funding from the Children's Investment Fund Foundation, FHI 360 has been able to support rollout through local partners in the study district. The master trainings have been completed, and in the study district, approximately 120 HSAs and 25 clinic-based providers were trained in DMPA sub-Q, including self-injection. This is an ongoing project, so please stay tuned for more updates. Next slide, please. We have several papers that have been published open access and are available online for those of you who would like to read more about the study and our findings. And we also have a 4th paper that will soon be published in the Global Health Science and Practice Journal, so please be on the lookout for that paper as well. Thank you very much for your time and interest.
Thank you so much, Holly. And now I'm going to turn it over to Jane Bertrand from Tulane University to talk about piloting self-injection at community level in DRC.
Good morning, everyone. Next slide. A quick introduction to DRC. As we know, it's one of the poorest countries in the world. It's also one of the largest countries in sub-Saharan Africa, the size of Western Europe. Next slide. The work I'm going to present today builds on an initial pilot we conducted in 2015 to test the acceptability and feasibility of DMPA-SC being distributed by medical and nursing students at the community level. In 2015, this was an innovation because previously only doctors and nurses administered injections in the DRC. The results of this pilot were very positive. The DMPA-SC clients approved both of the method and were satisfied with its delivery by these student providers. For the student providers, it provided them an opportunity to practice clinical delivery in a community setting and also give back to the community. The Ministry of Health authorities who were contacted were also supportive to this approach. And this paved the way for the current study on the self-injection of DMPA-SC. Next slide. This study was conducted in 2016 and 2017, and it was to determine whether or not these same students, this time mostly nursing students, could capably train women at the community level to self-inject, learning both the acceptability of this for them and some of the obstacles that we might encounter. We conducted this in 3 of the 35 health zones in Kinshasa in the context of so-called campaign days, where interested women, those interested in getting family planning services, were alerted as to the day and could congregate at a predetermined community location. The medical and nursing students would give a general overview of a full range of methods, and then were able to make 4 methods available on site. That would be pills, cycle beads, condoms, and DMPA-SC. The providers of clients then split into dyads for individual counseling, and women could choose any of these 4 methods. Next slide. Those who chose DMPA-SC could then decide, did they want to try to learn self-injection, or did they want the so-called provider administered, which meant that the student would give them the injection. Our research methods on the component of the research that involved the clients included 4 rounds of data collection. The initial uptake of DMPA-SC, followed by studies at 3 months, 6 months, and 12 months. At the time of the initial survey, the DMPA-SC user could opt for one or the other, that is to say self-injection or provider injection. Both a major strength and a major limitation of this study was the community context in which this research was conducted. We were not in a clinic setting where we had easy access to client records, for example, and could follow individual cases. Rather, this was much more a community opportunity for women to have access to low or free contraception, in which we felt would greatly increase their access. As a result, we had very high loss to follow-up, but we felt that we also got a very good look at what happened in the context of this community approach. Next slide. We were actually quite surprised that of the 850 clients that opted for DMPA-SC at baseline, 3/4 chose self-injection. This in a context where we wondered if it was going to be acceptable at all. So we were very surprised with this very high level. The profile of the self-injectors were mean age approximately 27 years, 3/4 were married or in union. Virtually everyone already had at least 1 child, the mean number being 3 kids. As previously mentioned, less than half had previously used a contraception, thus giving us the impression that we were bringing new clients to the contraceptive use. Next paragraph. Next slide. What were their reasons for choosing self-injection? Many cited the ease of use at home, this idea of I want to be able to control the method myself, I'd like to learn new things. We asked clients, was it difficult to perform self-injection? And most of them felt no, it was actually very easy or somewhat easy, and the percent stating very easy greatly increased between the first and the second injection. Yes, almost everyone had been anxious at the initial injection. There was fear of needles, fear of the pain. They'd never done this before. Were they going to do it correctly? But this fear subsided over time. Next paragraph. We found that the clients actually had a very high level of confidence in their ability to self-inject. The left-hand bar shows the percentage that indicated very good to the readiness after their training to self-inject, their confidence of how to perform self-injection. Again, over 80% felt they were confident to follow the instructions in the booklet on self-injection. And again, over 80% felt confident that they would know when to perform the next injection. Next slide. We also wanted to know the attitudes of these clients toward the services provided by the medical and nursing students who had instructed them in how to self-inject. As in our previous pilot, the large majority did not realize that these were students. Because they wore a vest, because we were often adjacent to a health center, they assumed that they were part of the clinical establishment. Once they were told that the service provider was a student, nonetheless, the levels that felt that they were comfortable about being trained in self-injection by a student were still very high. Close to 80% were very comfortable, another 10% were somewhat comfortable. So the issue of using students in this role, again, was shown to be very acceptable. Next slide. We also had high levels of satisfaction with the services. In this slide, you can see that close to 90% were very satisfied, both with the information and counseling about cyanopress and the other methods that they had received, and the explanations of how to perform self-injection. Not shown here, but similarly high levels would recommend this method to a friend. Next slide. The DRC had more of a problem with the disposal of the injection of waste than, say, in the case in Ghana or Malawi. What we found was, with this first experience, that close to half, both or at the 6-month and 12-month follow-up, were using either trash cans or latrines. And this became a major focus of next steps for this implementation process. Next paragraph. Next slide. Okay. The results very much demonstrated test of concept. Yes, it is acceptable and feasible to teach women in Kinshasa to self-inject DMPA-SC. The question was now how to take this to scale. Was this something that we could expand to all the health zones in Kinshasa? Could we expand it to other provinces in the DRC? We were faced with what I call 3 pesky questions on the scale up. Where would interested clients get their doses of DMPA-SC at low cost? How would they demonstrate to the person providing the doses that they were competent to self-inject? Or is it important that they did demonstrate? Could one simply go in and buy a dose from anyone interested in selling it? And where would they dispose of the Uniject device after use? Next paragraph. Next slide. Go back, please. This pilot study has paved the way for further investigation of this. The mechanism we are now using in the scale-up is the integration of family planning into the nursing school curriculum, which has now taken place in 3 of the 26 provinces of the DRC and is scheduled to continue. The nursing students learn to deliver contraception as part of their curriculum, and will use this as a vehicle for training more students in basic family planning, as well as instructing in self-injection of DMPA-SC. We are currently developing the research protocol for a test of implementation prior to this scale-up. And again, the 3 main questions are going to be the source of resupply for DMPA-SC, how do you demonstrate client competency, and how do we more effectively dispose of the devices. Next slide. I thank my collaborators on this, the Ministry of Health, the study team from Tulane University, and our donors, both the Bill and Melinda Gates Foundation and UNFPA in the DRC. Thank you very much.
Great, thanks so much, Jane. And thanks everyone for continuing to submit your questions to the Q&A section. We are tracking them all and look forward to our discussion shortly. So we have 2 more presentations. I'm going to now introduce Maimouna Ba from PATH, who will be presenting results from Senegal. Maimouna.
This presentation will focus on the injectable continuation study recently conducted in Senegal. Next slide. Here are the key indicators of reproductive health in Senegal. As you see, the total fertility rate is 4.6 children per woman in 2017. And I like to note that this rate has decreased from 5 in 2010 to 4.6 children per woman in 2017. Next slide. Focusing in contraception use, we can see that with the graph that Senegal is making good progress to increase the contraceptive prevalence rate and reduce the unmet need. Just to emphasize that injectable remains the most popular method in Senegal with a sizable share of 10% among method mix. Next slide, please. This slide is a reminder of the operational feasibility study, which show high competency on DMPA-SC with 90% of women who were competent at their first injection and 72% who were births on time and proficient at their second injection. This study showed also high acceptability with 66% who reported that the second injection was very easy and 72% who reported the same for the third injection. Also, nearly all women expressed a desire to continue self-injecting. So, self-injection is feasible and acceptable in Senegal for the majority of women. Next slide. Concerning the continuation study, it was conducted in 2017 in 2 regions in Senegal. It was a non-randomized prospective study which compared 12 months continuation rates for 2 groups: women selecting self-injection of DMPA-SC and women selecting DMPA-IM administered by a provider. In terms of procedures, participants in the self-injection groups received individual training by a licensed nurse and were supervised for their first self-injection. Those who were competent were given an instruction booklet a reinjection calendar, and 2 units to take home. For the IM group, participants received each injection from a provider at the health facility. And all participants were interviewed after each injection to assess injectable continuation at 6, 9, and 12 months. Next slide. In terms of population characteristics, we have 2 different population profiles at baseline. Women who choose self-injection have higher education level, have more experience with DMPA-SC administered by a provider in the past, and are more receptive to new ideas. In the contrary, women who choose DMPA-IM have more children, more reported needle anxiety, and have more concerns about transportation costs to the health facility. Next slide. The training results show that the majority of women found self-injection easy to do in each phase. If we look at the graph, we can see that the self-injection is easier over the time. The analysis shows also that activating the device and inserting the needle were reported as the most difficult steps. Next slide. Concerning knowledge of correct reinjection dates, it was higher among self-injectors at each point of time. However, we can see with the graph that an important part of women faced challenges to reinject on time. In fact, most of them found too hard to calculate injection date with the calendar provided during the training. Next slide. For waste storage, we didn't give a container to the participants, but we instruct them to use a container from their households for the storage, then discard the device in the latrine or return it in the health facility. If we look at disposal practices, we can see that women who still have the used unit decrease over the time, while those who disposed it in the latrine increase. Also, we see at each injection that few women return the device at health facilities. That's because we were in research context, so women hold the device until they interview and give it to the interviewer. If we look at the graph in the left, we can see that fewer women stored the used device in a household container. That means some women face challenge to store the device safely and to disposal. Next slide. In terms of continuation, we can see in this slide that continuation is higher among self-injectors compared to DMPA-IM users. In-depth analysis of characteristics show that this higher continuation is not attributable but is attributable to self-injection itself. Next slide. To summarize, we can say that in Senegal, self-injector may be more educated, more experienced with DMPA-SC, have less injection anxiety, and are more likely to embrace innovation. And we can say also that self-injection enables women to continue using contraception longer. However, women continue to face challenges to identify correct dates, so developing injection reminders strategies may be relevant in Senegal. Just to note that this continuation study and the previous feasibility study provided sufficient evidence to the Ministry of Health, who approved the national self-injection rollout. So the ministry is currently integrating DMPA-SC self-injection into national family planning program. And providers training is underway in 2 regions, Jobel and Seju, and will be continued in other regions in 2019. Next. Thank you for your attention.
Wonderful. Thank you so much, Maimuna. And our final presenter now, Alan Namagembe, will talk about the results from self-injection research in Uganda and the current status of the rollout there. Alan?
Thank you, Jen, and all the previous presenters. Good morning, good evening. I'm going to present on self-injection research in Uganda and the way forward. Next slide. I'll want to start with by drawing our attention to DMPA-SC scale-up in the context of Uganda and our FP 2020 commitments. Uganda is making substantial progress towards meeting our FP 2020 commitments, where we set a goal of reducing unmet need by 10% and increasing our contraceptive prevalence rate to 50%.
Hi, Alan. Sorry to interrupt. We're getting a few messages that there are a few folks on the line that can't hear you very well. Could you get closer to your microphone or speak a bit louder so we can make sure to catch everything you're saying?
Okay, thank you. Is this better?
Yes, that's a bit better. Just keep at that volume.
Okay, so one, I want to draw attention to the DMPA-SC scale-up in context of Uganda's FP 2020 commitments. Uganda is making substantial progress towards meeting our FP 2020 commitments, where we set a goal of reducing unmet need to 10% by 2020 and increasing our contraceptive prevalence rate to 50%. As per the most recent PMA 2020 survey, our unmet need is currently at 26% of the married women, and our CPR has increased from 26%, that is the DHIS 2011, to 36%. And part of that story involves DMPA-SC. If you look on the slide, the map shows progress towards scale-up of DMPA-SC across the country. The dark orange are districts where training of facility-based providers is complete, and the lighter orange is where we have trained, but there are still gaps. Next slide. With respect to self-injection, Uganda was the first country in Africa to embrace the concept of self-injection, launching a self-injection feasibility and acceptability study in 2015. The study established that the vast majority of the women trained one-on-one by a nurse could demonstrate competence in injection technique and reinjected on time without a reminder 3 months post-training. Nearly all women expressed a desire to continue self-injection, and by the time of the second injection, 98% reported it was very easy to do. We found out that self-injection is feasible and desired in Uganda, but we wanted to find what difference will it make for the family planning program. And that brings us to the continuation study. This was launched in 2016 and were designed to assess whether self-injection can increase injectable continuation. We enrolled 561 women in the self-injection group and 600 women in the provider administration group. Participants in the self-injection group were trained, supervised at the first injection, and were given an instruction booklet, a reinjection calendar, and 3 units to take home for independent self-injection. Participants in the provider administered group received each injection at the clinic. All participants were interviewed at enrollment and after the 2nd, 3rd, and 4th injections to measure continuation throughout the 12 months. Next slide, please. It's important to note that women were not randomly assigned to groups. So there are likely to be differences between the types of women eager to try self-injection and the type who are not eager to do it. And indeed, they were. On the slide, women who chose self-injection were more of a high socioeconomic status, more empowered, had support from communities where they lived, and had experience of DMPA-SC before. Compared to the Depo-IM users, were more likely to report high needle anxiety. And all these were statistically significant at a P level of 0.05. Next slide. This slide shows a Kaplan-Meier curve of the probability of continuation over the entire time period for women self-injecting, which is the red line, and women receiving their injection from a provider, the blue dashed line. At each point in time, from the 2nd injection on, women in the self-injection group showed higher continuation. By the 4th injection, which provides pregnancy prevention through 12 months, 81% of the self-injectors were continuing, compared to 65% of the women who were receiving their injection from a provider. Next slide, please. So in the previous slide, we found significant difference in continuation, but perhaps this could be in the difference in the continuation due to the type of women who chose self-injection or maybe selectivity. So we conducted a multivariate analysis to address that concern. And the result of the Cox regression analysis showed that controlling for background characteristics such as education, parity, age, and others, self-injection is significantly associated with longer continuation. Factors that decrease the risk of continuation were more education, more children, and having a partner who supports family planning use. Factors that increase the risk of discontinuation included living in a rural area and age greater than 25 years. Next slide. So with respect to age, we found an interesting pattern. And as I mentioned in the previous slide, we found lower continuation among young women, implying being young puts you at a risk of discontinuation. However, it turns out that the relationship between age and continuation is only among those receiving the injection from a provider. The red and blue lines at the top of this graph are self-injecting adults and self-injecting youth. Their continuation rates are indistinguishable. And the yellow line is adults receiving DMPA-IM from a provider, while the youth receiving injections from a provider are coming at the bottom with much lower continuation rates. It may be that self-injection is particularly advantageous for young people in Uganda. Next slide. So moving forward, the self-injection program is being evaluated across channels to identify the most successful program model. This evaluation is exploring injection competence, acceptability, health work satisfaction and perceived feasibility, health work practices, cost efficiency. And this we are implementing outside a research setting. Results of the evaluation will be ready in March 2019. And part of this evaluation is also looking at self-injection in the private sector, where we are conducting monitoring and evaluation, and the results will be ready in June 2019. Next slide. A few monitoring results from this program for 1 year, from November 2017 to November 2018. We are seeing more than 7,000 women self-injecting in the program. Next slide, please. But who are the first self-injectors in Uganda outside the research setting? We are seeing 33% are using family planning for the first time, which is very consistent with the previous studies, studies presented. And 56% are younger than 25 years. Next slide, please. So what are some of our takeaways for Uganda? It has, one is self-injection has been successful at reaching new family planning users, young women, and women who reside far from the health services. We are also learning that community health workers are integrating self-injection in their work more easily compared to facility-based health workers. We are happy that these are within the communities and improving access to family planning services. Thank you.
Thank you so much, Alan. And thank you to all the presenters and to everyone who has submitted questions. We have about 23 minutes remaining for moderated Q&A, so let's turn to that now. Before we get into some of the specific questions about self-injection, I just want to address a couple kind of broad questions about the method and self-injection. In particular, there were several questions about how this product, DMPA-SC, is positioned in the method mix relative to IM, and for example, whether it's only offered for self-injection or health worker administration. So I'll talk to that very briefly and then ask the panelists if there's anything that they'd like to add. So the first introductions of DMPA-SC or Cyana Press began in 2014. And at the time, the first introductions of the product were solely through health worker administration. And that has been the precedent in most countries where the product is readily available, and then self-injection has been added on. Part of that was due to the regulatory and registration process. I think we're seeing a shift as the evidence base on self-injection builds, and I think as more countries are now beginning to introduce the product in their systems, side by side with the evidence base that you've seen today, they're looking at offering it to women either through health worker administration or self-injection. And then the other thing I would say with regards to IM is that, you know, what we hear from a lot of ministries of health is that they want to see evidence around uptake and demand of this product relative to IM in order to think about what kinds of procurement implications there are when both products are offered side by side. I would say that another question that came in had to do with how providers position it to women. And I think what we've seen, and I think Della presented these results well from Ghana, is that it's helpful to offer the product both for self-injection and injections from health workers, because women's decision to self-inject may change as she becomes more familiar with the product. Della, I would like to start with you. Is there anything you want to add in terms of how the product is positioned, whether from health worker administration or self-injection based on the current rollout and experience in Ghana?
Yes, thank you. For Ghana, the strategy is specific, that we're going to start with a training that's done by the provider. The first injection has to be that. And so from then on, in terms of self-injection being the ultimate, the client can take the 2 packs home and then come back to the facility. So of course, in the scale-up, more details are being developed, but the strategy is clear that it's going to have to start from a facility.
Thanks, Della. Maymuna, I wanted to ask you, because self-injection is now rolling out in Senegal, as you noted in your presentation. Can you speak to how these options of self-injection versus health worker injections are being offered to women in Senegal?
Yes, in Senegal, we have a cascade training approach. So it's first the provider who will be trained, and after that, we plan also to train the community health worker to train women who will come to the health hubs. So we will have 2 approaches for each type of providers. We use the same approach in the study for the qualified provider, and for the community providers, we adjust the training tools to be more receptive of community health workers. So self-injection will be offered in health facilities and into the community health, in community level. And for the training, it will be an individual training. The provider will train women. It will be an individual training, and now we have already revised family planning registers and all MNE indicators to include self-injection DMPA-SC. So at high level, all is ready to offer services for self-injection. We are in steps of training providers. Now we will start to train women for self-injection, and we will conduct evaluation to see how it goes.
Great, thanks, Maymuna. And just to clarify, when women in Senegal come to a point of service where self-injection is an option, they'll be given the option of either being trained to self-inject and then taking units home, or receiving an injection from a health worker if that's their preference, alongside any other family planning methods. Is that correct?
Yeah, this is correct. So this is correct.
Great, thanks, Maymuna. So I'm going to turn the topic over now to waste disposal, because we have received a lot of questions about that, and it's a very hot topic. I think all of our panelists shared some insights from their work on waste disposal. What I would like to do now is ask each of the presenters to share some insights from their countries now in terms of what the current proposed approaches to waste disposal in their countries, if it has evolved since the research study. And if not, if there's no clear solution or proposal, I would ask the panelists to talk about key questions that they're working to resolve. So first, I would like to ask Alan Namagembe to talk about the current approach to waste disposal in Uganda.
Thank you, Jen. During the studies, we were training women to find a puncture-proof plastic container with a lid to dispose of the Uniject, and they had also an option of disposing it in a pit latrine. Over 75% were disposing it off in a pit latrine and were not putting it in a puncture-proof container before the disposal. So in the self-injection best practices, which is outside a research setting, we are providing women with the container and are asking them to return the spent device at their opportune time when they get a chance to visit the facility. Preliminary results are showing that women are able to keep it in the container, but because of the timing, most of them had the device still with them. We are planning to conduct some more research exploring what exactly, after a given period of time, maybe time allowing them to have visited a facility, what exactly did they do with the device in the puncture-proof container? Thank you.
Thank you so much.
And the picture on the screen is what we are giving the women in Uganda.
Yes, exactly. Thanks, Alan. And I just want to note also that for the Uganda experience, PATH actually conducted costing and cost effectiveness analysis of self-injection relative to DMPA-IM from providers and facilities. And that analysis showed, first of all, that partly due to the increased continuation, self-injection is cost-effective relative to DMPA-IM injections from providers at facilities. We actually tweaked the analysis to see if every woman who self-injected received one of these containers from the health system, and it cost, I think it was a few cents. Alan, is that correct? It was still cost-effective. Now, obviously, that doesn't necessarily fully address how governments would identify a budget line for that commodity. And I think there are also questions in the private sector, but it's an additional point of evidence. Thanks so much, Alan. Holly, can you share the current thinking in Malawi around waste disposal?
Yes, can everybody hear me okay?
Yes,
great.
Loud and clear.
Oh, okay, great. So in Malawi, the Ministry of Health and the task force together have decided to introduce self-injection at the same time that they're introducing DMPA sub-Q. So the national rollout I described is simultaneously rolling out DMPA sub-Q as well as self-injection at the same time. So our providers, the Ministry of Health providers, as well as the private sector providers who will offer this, are being trained on all of it at the same time. And the way that they've decided to handle the waste is different than how we did it in the study. So in the study, because our outcome was continuation, and we were comparing provider administered versus self-injection, we wanted to remove any additional barriers, such as asking women in the self-injection arm to bring back the unit to a provider, because that could affect our outcome, our primary outcome, which was continuation. So in the study, we had self-injectors, we instructed them to dispose of the spent units in the pit latrine. And that was the most popular way to, that these women disposed of it. Some of them did some other things with them, but the vast majority of them disposed in the pit latrine and felt that that was a good way to dispose of the units. But disposal of sharps in pit latrines is not desirable in Malawi and other places. And so for the rollout, the Ministry of Health and the partners on the technical, the task force have decided to instruct women to find their own puncture-proof container and then at their convenience, return the spent unit to a community health worker or to the clinic for disposal in the community health worker's sharp box or the clinic's sharp box. So in Malawi, the community health workers have sharp box, in their homes or wherever they provide services in the community. So women, if can access that and not have to return to a clinic, but this is the plan and what everybody's being trained to do. Now it is different from the study, and we're not sure if that's going to be acceptable to women, if they're going to be able to do it, if it's going to affect continuation. So as part of our work introducing it, we are conducting implementation science research alongside to study what women are actually doing with their waste and how they feel about what they were trained, if they're doing something different than they were trained to do, why is that, and what are their ideas for the future. So hopefully we'll have pretty soon some information about how women are actually disposing it and how this plan is working, and maybe some new ideas to try if this plan isn't working. We're actually also implementing a similar protocol, the same protocol in Uganda sites where FHI is helping support the rollout of DMPA sub-Q and self-injection in districts where they're not providing these containers. So again, they're asking women in these particular areas to find their own containers and then at their convenience return the spent units to a community health worker or the clinic. And again, we're going to try to collect information to find out what they're actually doing and how this is working. So please stay tuned for more information out of Uganda and Malawi on this very important topic. Thanks.
Great. Thanks, Holly. It sounds like we have data coming from a few different partners and countries about that issue. And I'm going to keep us moving because waste disposal, again, is always a hot topic. But there are lots of important issues when we talk about self-injection. The other thing I would highlight is that the Access Collaborative team at PATH and JSI have been working on a set of slides and a brief summarizing key issues around household level waste disposal, because this is a broader issue than just contraceptive self-injection. And so be looking for that on our resources in the next month or so. I'd like to turn to the topic of client training because I think we have a lot of questions about that. In particular, there is a lot of curiosity about how to support women who have relatively low levels of literacy or low education can be a proxy, I know sometimes. How can they learn to self-inject? And so I'd like to ask our panelists to talk a little bit about approaches they took in their studies to make this practice accessible for a wide range of women. I'm going to start with Jane in DRC. Can you speak to the approaches that were used in DRC to train women to self-inject and specifically steps you took to help women with lower literacy learn how to self-inject?
Thank you. Given the neighborhoods in which we were doing this community level training, almost by definition, the levels of education and literacy were quite low. It was really a demonstration by, or learning by visual, watching what was going on, watching the procedure. We did have mannequins, that is to say, not always the professionally purchased ones, but other kinds of locally made devices that women could have the opportunity to practice on those before actually practicing on themselves. And this seemed to work out quite well. Once a woman had decided she wanted to do it, she simply followed the example of the students in giving the training and proceeded with those instructions. The literacy thing did not seem to come in. One might wonder if, in terms of being able to use the calendar, to figure out when to re-inject, I think that there was a sense of if she couldn't, someone else in her household would be able to help her use that. Some women, though, talked about, they just felt that they were going to be able to remember without even a device, and this may come from skills one develops if one is not able to read. in short, we did not find literacy a barrier.
Great. Thanks, Jane. That's really helpful. Alan, can I ask you to talk briefly about a couple training aids from PATH, including the one-page client aid as well as the video that would be hopefully helpful for lower literacy women?
Thank you, Jen. So PATH developed a one-page job aid, which is very visual, to help the non-literate women learn how to self-inject. And we're also exploring the use of a video to self-train by women to learn how to self-inject. The job aid, so far we had some results coming through for the job aid, and women appreciated using that as to remind themselves of the injection technique when they are doing it independently. The video has just been introduced, so we are yet to evaluate that. But just to say, we still had some low performance from the women who never went to school. And in our, we are seeing they need more support and also practice to get it right. Thank you.
Thanks, Alan. So I want to we have so many different questions, and so I think what's going to be probably a best way to close is to note that there are a lot of topics that people have been asking about. So, for example, what are countries planning or what are implementing partners planning in response to results from the ECHO trial that are going to be released mid-year this year? Other key questions about training include how many units women were given to take home, which I think may be different in studies, and then as partners move to rollout. Questions about the private sector, questions about male involvement, questions about reminder systems. And given that we're close to time, and I think it's quite hard to prioritize all these questions, what I would like to propose is that, and I would encourage all of you to shift this dialogue from this webinar onto the online platform of the DMPA-SC Access Collaborative Learning and Action Network, and we'll include clear links to that in the follow-up from this webinar. If you're not already a member, we will help facilitate that for you. But I would propose that as part of moving on from this webinar, we're going to take specific topics that have been raised and were not able to be addressed in the time available and try to facilitate answers to questions and discussion on that online platform of these specific topics. So we'll facilitate follow-up there. I think the other advantage of that is that we have 5 very knowledgeable panelists and presenters on this webinar who can answer questions, but there are also implementers in many other countries who have experiences that they can bring to bear. So we will follow up. If your question was not answered today, we will follow up via the online platform of the Learning in Action Network, and we would encourage you to feel free to repost your question there if it was not answered today. So I think with that, we are at time. Really appreciate everybody's participation. Again, our presenters are some of the foremost experts on self-injection in the world, and so really appreciate their participation and preparation today. And thanks to all of our attendees for joining us.
Okay, great. Thanks, Jen, so much, and thanks to all of our presenters today. Jen actually covered what I was going to close with, which is please head over to our online platform for any unanswered questions, and hopefully we can continue the discussion there. So thanks again, everybody, and have a great day.